Um, he is a specialist in refractive surgery as well as glaucoma and cataract diseases and surgery. In 2003, Dr. Oates was one of the nation's first physicians to offer conductive keratoplasty, a non surgical procedure which decreases dependency on reading glasses. Dr. Oates is a member of numerous ophthalmic societies and is an active staff member of the Cape Cod Eye Surgery and Laser Center in Sandwich and Falmouth Hospital. Today, Dr. Oates will discuss recent advances in the treatment of common eye conditions. Thank you so much for making time today, Dr. Oates, in your busy practice. Without further ado, Dr. Oates.
Well, thank you. Can everybody hear me? I can't tell. Is there? It's on. Is it working? Can you hear me now? Yes. All right. Miracle of audio visual. Thank you again. Thank you, Dr. Kimura, for having me. Listening to the hearing talk, it reminded me, harken back to my childhood days when my dad, who lost hearing in his right ear during a World War II explosion kind of incident, when driving with the five of us in the car, no matter what sort of mayhem went on, he would just open his window, and the air noise on the left and the deafness on the right worked great for him. Never a complaint. But anyway, let's go. I'd like to move forward and talk about some common eye conditions. So I thought we'd just touch base on these are the three main things that bring patients to see us and that we're treating every day, day in and day out, and that's glaucoma, cataracts, and macular degeneration. Very quickly, I'd like to just talk about the anatomy of the eye, because understanding these illnesses is really dependent on understanding the eye. This is just a picture of the eye. Light coming in from the left enters what's called the cornea. That's the clear window in the front of the eye, passes past the pupil, which is the colored part that we see in our eye. It then passes through a lens, which focuses the light onto the retina, right back here. The macula is an area about the size of the head of the pin. When you're looking at somebody or something, you're using the macula, a piece of tissue literally about the size of the head of the pin, which then processes that information through nerves, through the optic nerve, which then sends this information to the brain. The optic nerve is made of about 1 to 1.5 million nerve fibers. And those nerve fibers, this nerve is about the size of a pencil lead. So people talk about, well, can we replace an eyeball, or is there such a thing as an eye transplant? And the answer is no, and the main reason is because of the fine vasculature and the nature of this optic nerve. There's just no way to rewire 1.5 million nerve fibers that you would need to have working in order to see through an artificial eye. First we'll touch base on glaucoma. Glaucoma, about 3 to 4 million people in this country have glaucoma. Only about 1.5 million of us are aware of it. It's a silent disease, and it's a major leading cause of vision in the world and in the United States. What is glaucoma? Glaucoma is what's called an optic neuropathy. It's a disease of the optic nerve. And it's generally a gradual loss of these nerve fibers, which leads to loss of your visual field, which basically then you lose your vision. There are a variety of different types. So when you have glaucoma, you can't necessarily compare your condition with your neighbor's condition, your friend's condition. We also hear people comparing that my numbers are this, their numbers are that. You can't make those comparisons. It's an individual disease. There's many diagnoses or types of glaucoma that can affect the individual. We do know that one of the major risk factors for glaucoma is intraocular pressure. And right now, it's the only thing we can treat. So regardless of what the problem is, our only treatment lies in treating the intraocular pressure. Other risk factors besides elevated intraocular pressure is your family history, genetic factors, race, hypertension, myopia, are all associated with increased risks for glaucoma. So let's talk about, again, the physiology here. What is glaucoma? Inside the eye, there's an area called the ciliary body, and this is part of what's the iris structure. It lies behind your iris, and it creates fluid inside the eye. That bathes the eye. It provides the nutrition to the inside of the eye to some extent. This fluid curves around the iris, comes out through the pupil, and then gets reabsorbed in the angle between your cornea and your iris. This is known as the trabecular meshwork that you're looking at right here. So under a microscope with a certain, called a gonial lens, in the office we can examine this area of the eye and see if the trabecular meshwork is open and see if there's any conditions specifically affecting the trabecular meshwork. If this area is compromised, the drainage is no longer operational and the pressure goes up inside your eye. And when the pressure goes up, the pressure is pushing against the wall of the eye, and one of the intrinsic areas of weakness, is the area where that optic nerve, seem to be not going backwards here. Okay, there we go, sorry. The optic nerve is an area of a weakness. The wall of the eye is interrupted where the nerve comes through. So that pressure is pressing against all of the outside of the eye, including the area of the optic nerve. And over time, the optic nerve can undergo changes. Here we see what we call a perfectly normal optic nerve. Here's a nerve that has already suffered some damage. Some of the nerve fiber, which is the orange part, is disappearing. They're dying off. And you see what's called the cup. So when we're looking in the back of your eye, doctors, what are you looking at? What are you looking at? This is one of the major things that an eye doctor will be looking at when they're examining your eyes. And this is an area where, this is an eye that now has advanced glaucoma. You can see that a lot of the nerve fibers have disappeared, leaving just the structures that support the nerve fibers in place. And that's the yellowish that you're seeing there. We call that cupping. That's the expression that we have for that. It's cupping of the optic nerve. Now, part of the problem with diagnosing someone with glaucoma is sometimes their pressures can be normal, they can be high, they can be low. That does not make a diagnosis of glaucoma. What makes a diagnosis of glaucoma is a nerve that looks like this or a nerve that's gone from here to here. Okay? Even this nerve could pass as normal. Anatomically, there's a lot of difference the way the nerve appears. Not everybody's nerve looks great like this. A lot of us have nerves that look like this. So the question is what's happened over time? And that's why the importance of annual, or not annual, but regular eye exams. Because if you're seeing the same doctor, he'll document how your optic nerve looks. We document that in our chart. So 5 years later, you come in, if you had an optic nerve that looked like this first slide, and then you come in and you have an optic nerve that looks like this, even if your pressure is normal, all of a sudden you are now there's a strong suspicion of glaucoma. You'll undergo a workup for glaucoma and be followed or treated for glaucoma. You don't want to walk in your doctor's office with a nerve like this. By this time, very often people are suffering visual loss, and once you start having symptoms from glaucoma, it's often very difficult to control the disease. This is, again, is sort of a picture of what the optic nerve looks like. These are the individual nerve fibers that sort of sweep up across the retina and make a turn, a right-hand turn, into the optic nerve. And again, there's about 1.5 million individual of these nerve fibers. Now, one of the recent things that has come along is our ability to, again, diagnose glaucoma with technology that wasn't available very long ago. Between lasers and high-speed computers, you can use laser light now to actually measure the thickness of this nerve fiber layer. And that's what's damaged or lost in glaucoma. In the right eye, we see a nerve which is normal. On the left eye, we see an eye that where the red is where the nerve fiber layer has thinned out. And that's pretty diagnostic of glaucoma. We use visual field testing. Everybody, who likes their visual field? I'm sure many people in this room have glaucoma. Everybody says, do I really have to do the visual field test? Well, the reason is yes, you do. And the reason is right here. If you have a defect on your visual field, or even if you don't, if we are picking up a change in the visual field, your glaucoma is being inadequately treated. No matter what your pressure may be, no matter what else is going on, if you're having a progressive visual field loss, more needs to be done. And that's why these visual fields are probably the single most important way we can measure our effectiveness in treating you for your glaucoma and preventing you from losing vision. So that, again, the only treatment we have is to lower your pressure at a level that no longer causes damage to your eye, all right? And this can be unique to you. Again, there are people with pressures of 30 who are fine. There are people with pressures of 10 who are going blind from glaucoma. So we have to monitor you as an individual on a regular basis to determine the pressure that we are treating you at is effective. If not, we need to lower it further. That's why you can't compare your pressures with your neighbor's pressures. And we hear people talking in the waiting room all the time. What's your pressure? What's your pressure? Well, it's like a card game going on out there. See who's got the lowest pressure or the highest pressure. I don't know. But how do we manage glaucoma? There's basically three methods that we have available to us. Medical treatment, which is drops. There are pills, but primarily it's drop therapy. There's laser therapy, and then there's surgical therapy. And surgical therapy traditionally had been major operations on the eye with a relatively high incidence of complications, and can be a stormy postoperative course. And there's a new procedure, which I'm going to talk to you a little bit about, and it's called MIGS, microinvasive surgical glaucoma surgery, which has only come on in the last 2 or 3 years we've had available to this technology. You can see that there's a variety of different drops that are available to us. They are more or less tolerable. They have to be used more or less frequently. They have different side effects. So basically, the purpose of the drop is to decrease the production of fluid that's going on inside your eye or to increase the drainage of the fluid leaving your eye. That's all these drops can do for us. And again, sometimes we have to use these drops in a variety of combinations. And it can be cumbersome to the patient, and these drops are getting more and more expensive, as we've already heard from the pharmaceutical issue that was brought up with dermatology. So unfortunately, these are the tools that we have available to us. And this, again, is the problems that we have with eye drops. Patients, by and large, don't like them. And there's a real problem with compliance. Often patients are not having symptoms as far as losing their vision. So why am I taking these drops? They're expensive. They don't see any better. Matter of fact, they probably see worse by using drops because it can be a little bit irritating to the eye. It's inconvenient. There are physical limitations with people who have arthritis that can't handle the drops. There are side effects. They can be uncomfortable. They can affect your vision. They can cause some pigmentation and redness around the eye. They can cause systemic side effects occasionally. And there's problems with insurance coverage. More and more of these drops are not being covered adequately. And again, there's issues with effectiveness. Not every drop is going to work on every patient, so there may be a lot of trial and error involved in getting a drop that works well for you. If we're not able to treat your glaucoma with an effective medical regimen, typically we go on and talk about laser. Laser is safe, it's easy to perform, it's a standalone treatment for glaucoma, or it can be adjunctive to your medical therapy. It's typically a one-time treatment, although it would likely to be repeated in the future. There are certain limitations to this. It's an expensive equipment to do it. There's limited pressure reductions. We often don't get the pressure as low as we want with a laser procedure. And again, it's temporary, although we could talk about years when we mean temporary. How is laser done? It's done with a patient sitting at the slit lamp. If anybody's had an eye exam, if everybody's had an eye exam, it's very much like sitting a slit lamp. A lens goes on the anesthetized eye. Laser light is then applied to that area of the trabecular meshwork I showed you before. And our current lasers, instead of causing damage to the trabecular meshwork, they cause a stimulation. They cause a proliferation of cells which absorb the fluid in the eye, thus lowering the pressure. So it's a non-destructive procedure, and it often can be very effective. If we can't get adequate pressure with our laser and drops, then we have to move on to surgery. This is typically invasive type therapy. It's our best way of getting the lowest pressures that in some patients we have to achieve. There are variable results. There's no guarantee. Cataract surgery, all our friends have had it. Many people have had it, and they get great results. It's pretty reliable. Glaucoma surgery is much more variable on its outcome. There is a high incidence of complications with glaucoma surgery, and there's increased risk of serious infections to the eye on a lifelong basis after having some of these procedures. So how are these done? Very briefly, an incision is made underneath what's called the conjunctiva, the membrane that covers the surface of the eye. We then kind of make an incision through the wall of the eye, and we provide a channel for the fluid to escape from the inside of the eye to the surface of the eye underneath the conjunctiva. And typically what we do is we form what's called a bleb. And this is where the fluid is now exiting the eye and being reabsorbed by the eye. Now we have something called, again, these MIGS procedures, and these have demonstrated markedly improved safety profile. They are designed to reduce or eliminate topical therapy and maybe prevent the need for more aggressive surgery that I just demonstrated. They can be also incorporated with other eye surgery, and in fact, some of these can only be done when you're having cataract surgery. This is one of the devices that's available to us. It's called an iStent. You can see the size of this thing. I mean, it's minute. It's barely visible. And it can be placed in, this is a little device that then slides this into what's called the trabecular, into the canal of Schlemm, which basically cannulates the trabecular meshwork. Glaucoma is felt in many cases to be a blockage at that membrane where the fluid enters what's called the canal of Schlemm again and then exits the eye from there. So these are sort of like a cannula that goes in there, and it provides a direct pathway past the trabecular meshwork into the canal of Schlemm, allowing the eye to drain. These only take a few minutes. You'll never know you ever have had it done. I've done hundreds of these. I don't have had a single complication with it. The only downside is sometimes you don't get great pressure reduction with them. But again, if you're having cataract surgery and you have glaucoma, I think I think it's important to have something like this considered during the course of your operation. This is the next one that's come along. It's called the CyPass, and this enters a different area of the eye. Rather than going into the canal of Schlemm, it goes into an area between what's called the uveal tissue, which is the tissue inside the eye, and the wall of the eye, and allows the fluid to drain in that space. This space is responsible for maybe 20% of the normal absorption of fluid out of the eye. By putting this stent in there, it increases that dramatically. And it's another method that can control the intraocular pressures. And this is the last of these that is now currently available in the United States. And this is a little tube. And the tube is passed by a needle through the cornea across the eye, as we're seeing here. And it goes through the wall. So instead of making a big incision, it goes through the wall into the area underneath the conjunctiva. And this provides a drain from, again, what's called the anterior chamber of the eye into the subconjunctival space. That's the way a trabeculectomy works. That was the first major operation I showed you. This can be done in a matter of minutes. There's a much lower complication rate. It does require a fair amount of postoperative care. But again, it's a big advancement in some of the techniques we had available to us earlier. So these MIGS, which is probably the hottest thing in ophthalmology right now, is it can obtain adequate intraocular pressure control, has reduced or eliminated the need for topical therapy in many patients. Some of these can only be done during cataract surgery, and they are FDA approved. So basically, talking about the recent advances in the diagnostic studies that we can do to monitor, treat, follow, and diagnose glaucoma, and our ability to manage patients has, again, dramatically improved over the last 5 years. I'm going to move on to cataract. We're going to have questions and answers. So I know I'm covering a lot of area very quickly, but let's talk about cataract. So again, there's a lot of misunderstanding about what a cataract is. A lot of people say it's a film. They think it's a mass in their eye. They think it's a growth. It's really none of the above. The eye, I apologize. As we showed before, the light comes through the front of the eye, goes through the pupil, and then it gets focused onto the retina. There's a lens inside the eye, as I showed you before, and the lens can get cloudy. And a good example is lucite plastic gets cloudy over time. It's an oxidative process of that material. Well, our lens undergoes the same process. So our lens, due to UV light, just due to aging, it gets cloudy. And as it gets cloudy, it starts interfering with the passage of light through the lens. So instead of light being focused nice and sharply onto the macula, it now gets dispersed in the eye. And this is what causes glare when driving at night. So instead of having one, like the headlight just being focused as a sharp point, what happens is the light gets dispersed. And it bathes the whole back of the eye with light. And that way it's hard to discriminate the light source itself. A good analogy is like looking through a clear glass of water. You put a drop of milk in it, what happens? Same thing is happening inside your eye. And this is what a cataract can look like to a dilated eye. Normally, this would be pitch black, just pure black. But a cataract gives it a kind of a jaded appearance in most cases. It's common. It's normal aging of the eye. It reaches clinical significance, and about 40% of us will come to get cataract surgery due to the fact that the cataract is interfering with our ability to function. It's the most common surgical procedure performed in this country. It's got a very high success rate, 98, 99%. It's the highest of any procedure done in modern medicine today. And the goal of the procedure is to restore vision and also potentially reduce the dependency on spectacles. The cataract does not, again, harm the eye. So it's not a medical diagnosis. I always say to the patients, they say to me, well, should I get my cataract done? I say, it's not what I see, it's what you see, and how it affects your lifestyle. And the analogy I use is you have an airline pilot on one side of the spectrum, you have a 90-year-old sitting in a nursing home on the other side of the spectrum. And they have very, very different needs for their eyes, and they would come to get cataract surgery at different times. And for the rest of us, we lie within that spectrum. So when your cataract starts interfering with your ability to drive at night, to read, to watch TV, whatever it is, that activity that's being impaired, that's the indication for going ahead with repair of your cataract. It's not the fact that you have a cataract, because we all have cataracts. After the age of 50, we're all going to have some degree of cataracts. The history, very briefly, some interesting things. Cataract surgery was done in ancient Egypt. It was a couching procedure. What they did is they used to stick a needle in the eye, and they used to push your cloudy lens out of the way. That's how they handled the cataract. And so the lens would be out of the way, and so now light could get to the back of the eye if the eye survived the operation. But until they developed these thick spectacle glasses, the aphakic glasses, I'm sure remember your grandparents wearing, your parents may be wearing those big thick glasses, there was no lens to replace the original lens. And there was not the surgical techniques to do that. So people ended up with aphakic glasses. Sir Harold Ridley is an interesting guy who's an ophthalmologist in England who took care of this gentleman right here. And he used to fly the Spitfire. And he found that in this gentleman that they tried putting lenses in eyes, and inevitably the eye would react to that, it would become inflamed, and the operation would fail, the eye would die. He found that plexiglass that was knocked off the windshield of his plane that ended up inside his eye tolerated it. So he decided to try and produce intraocular lens produced out of the same plexiglass material that they were using for the Spitfire, and in fact it worked. And he was the first one accredited for giving us intraocular lenses, and that's why we can see without big, thick glasses after cataract surgery. So we can thank these two gentlemen for that advancement in cataract surgery. Charles Kellerman came along, and another interesting thing, he wanted to do cataract surgery through a small incision. We used to have to cut half the eye open to extract your lens, and then we'd put in the implant and sew it all up. This is a big incision. It made the eye very susceptible to trauma, to infection, to problems with the vision. People were basically at bed rest for days to weeks, sandbagged, head sandbagged. People were dying of pneumonia. They were dying of pulmonary embolism. There are eye hospitals built to take care of these patients. Well, Dr. Kellerman, he was looking for another way. He was always in search for a smaller way to do cataract surgery. Well, one day he had his dog at the vet, and the dog was cleaning his teeth. And the dog, he was using this device. So Dr. Kellerman said, what are you using? And he said, it's an ultrasonic device. And what it does is it was breaking up the tartar on the dog's tooth. So he decided, that sounds like something I could use to break up the intraocular lens. And he pioneered what we call small incision cataract surgery today. And this is why you can have your surgery done, and you could really be up and about the next day, resuming most of your normal activities. So we can thank Charles Kellerman for that. So when we do cataract surgery, what is our goal? Our goal is a safe operation. The health of the eye is paramount. And not only that, we try and put a lens in there that gives you the best vision you can get. And that's a challenge. There are different properties when we're looking at your eye that need to be addressed. The first is what's called the spherical error. Are you nearsighted or farsighted? And depending on the lens that goes in your eye, you can be left that way. There's something known as astigmatism. You may not have one focal point, you have more than one focal point. An eye that in front of the eye, instead of being shaped like a soccer ball, may be more like a football. And you have two different curvatures that need to be addressed in order to get sharp vision. That's what astigmatism is. And the other issue we have is presbyopia. When we're young, the lens in our eye is like a piece of jello, and you can change the shape of that lens. And that's why you can see up close, you can see in the distance. As you get older, that lens gets hard. You can no longer change the shape of the lens, so you go from a variable focusing system to a fixed system. And that's why we end up in glasses, that's why we need reading glasses. So the efforts are underway to try and, again, reduce the dependency on spectacles after cataract surgery, and these are the three areas that need to be addressed in order to achieve that goal. So this is shows you how astigmatism is, what it does to vision. So if you have a regular lens put in someone with astigmatism, this is what the vision would look like without corrective glasses, although glasses would correct it. Whether using a lens that has astigmatism built into it now, you have clear vision. Presbyopia, again, you have only, in the older lenses, only one focal point. So whatever the focal point was, that's where your vision would be. So if you're fixing the vision for the best vision for the distance, you'll need glasses to see up close. They now are developing lenses that have more than one focal point. Excuse me. So you can see this lens has two focal points. There are lenses that have what they call an extended range. So the focal point is not just a point, but it's actually an area. So you can bring things closer in. The closer something comes to your eye, it's going to be focused further back. That's just optics. So this lens allows things to be moved in and out, and they remain in focus. This, again, is an example of what that looks like. Here, someone has a standard lens for distance, so this may be their distance vision without glasses, but when they try and see up close, their vision is blurry. Here is a lens which, again, is either a multifocal or extended range lens. They can see their phone, they can see the distance, so they're much less dependent on spectacle lenses. When picking out a lens, this is kind of the model of the eye that people have to use to try and determine the power of the lens. Now, this has been broken down to formulas that we use, but you can see that there's a lot of it's a complicated process. You have to know about the curvature of the cornea, the inside of the cornea, the outside of the cornea, the position of your lens. Where is the implant going to lie in the eye? What is the length of the eye? What are the different distances inside the eye? So all these things are needed to be measured, and calculations are then done to try and figure out, when you have surgery, what's the best lens that we're going to put in your eye that's going to give you the best vision? What's going to focus the light on the retina where it needs to be focused? And there are theoretical calculations. There are calculations called regressive calculations based on past performance, but unfortunately, not everybody fits the model. It's theoretical. So when we do calculations, when you come in and you see me for cataract surgery, we're going to do measurements. We're going to measure your cornea. We're going to measure the length of your eye. And we're going to use calculations which are pretty good at picking the lens off the shelf that we're going to put in your eye. But not everybody fits the model. So there are people who are outliers who don't get the great results. Luckily, glasses will fix their vision, but a lot of people would like to be less dependent on glasses. This is sort of the latest technology we have in doing cataract surgery. It's called AURA. It's intraoperative aberrometry. This is the technology that was used to fix the Hubble telescope. I don't remember, but when the Hubble telescope went up, they spent billions of dollars on this thing. You know, all the brightest scientists in the world put the thing together. They figured out what it needed to do. They put it up in space, and it couldn't see. I remember this? So the Hubble had two lenses, a huge mirror and a small lens. So what they did was they shot a beam of laser light from Earth into the telescope, and then they measured the light that came out of the telescope. It's incredible that they can do this stuff. And from those measurements, they figure what lens do they need to change with the lens in the telescope to give it good vision. And they did. And they sent this space shuttle up there, changed the lens, and now the thing can see almost to the beginning of time. But so this is the same technology that we can use. At the time of cataract surgery, when the lens is removed from the eye, laser is shown into the eye, and then the device measures the light that's coming out of the eye. So we no longer have the compounding issue of your cataract anymore. Basically, we have a better optical system where we're just dealing with the cornea and with the retina, the length of the eye. And so the light goes into the eye, the light comes out of the eye, the machine analyzes the light comes out of the eye, it does a calculation and says you need to put an XYZ lens in that eye to get the best optical result. So we do this now at the time of surgery in eyes where we have concerns about the reliability of our standard formulas. And we're getting much, much better results as a result of this. So in summary for cataract, again, recent advances in our ability to measure the eye, to get the right lens in there, and in the technology of the lenses, not to mention the technical surgical techniques, provide a much safer surgery with much better outcomes for patients. So again, moving along, how am I doing on time? 5 minutes? We can do it. Macular degeneration is, again, that part of the eye, the macula I just showed you before, and it's a disruption of the outside of that tissue. It's the leading cause of irreversible loss of vision in this country. It affects over 10 million Americans. There are two major types. There's dry, which causes a gradual loss of vision, and then there is wet, which causes a rapid loss of vision. The risk factors, age-related macular degeneration. So age is number one. There's a significant genetic effect, environmental, and it's been shown that people with a diet healthy in deep green leafy vegetables and antioxidants have a 50% decrease in the development of loss of vision from macular degeneration. Smoking doubles the risk for macular degeneration. And again, just showing you the anatomy very quickly. And the light comes through the retina, through the retinal tissues. The photoreceptors are in the back of the retina, and behind that is the retinal pigment epithelium. When light hits a photoreceptor, the photoreceptor undergoes chemical changes. Those chemicals are then extruded out of the photoreceptors and go into an area called the retinal pigment epithelium, which then recycle these components and send them back to the photoreceptors for reuse. The problem with macular degeneration is that these don't get properly recycled. They build up in the retinal tissues and they cause disruption. And this is just shows you a normal looking macula. We're starting to see some of the development of these drusen, we call it. This is what we're looking for on your eye examination. This starts causing some impairment of your central vision, and then it actually can cause loss of retinal tissue, which causes even further loss of central vision. So there are advances in diagnosis, monitoring, and treatment of macular degeneration, which we should go through. This is, again, demonstrating some of the appearances of early macular degeneration and late macular degeneration. This is the dry form of macular degeneration. Again, we discuss the nutritional aspect of it. A very strong study by the National Institute of Health showed that people who took ARED-type formulations, these are eye vitamins, had a much lower or 50% reduction in developing macular degeneration. Now, one of the advances we had is although we can see macular degeneration, we often can't see some of the other aspects of macular degeneration that we really like to know about. Again, OCT, ocular coherence tomography, uses light, shines it in the eye, and gives us a picture which looks like this. This is almost getting down to the cellular level, like what we would do what we'd see if we took your eye out, we sectioned it, put it under a microscope. This is the type of view we're getting. This is showing you a colorization of one, and it's showing you the effects of macular degeneration. These little bumps are the drusen. This should be perfectly smooth, like here. And you can see it's gotten bumpy due to the presence of these drusen. So if you have macular degeneration, this is one of the reasons why these exams are important, because if we diagnose early macular degeneration, we can start doing monitoring. Typically, we tell people if you see any distortion in your vision, you should bring it to our attention right away. This can be distortion in reading. If you're looking at a telephone wire and it's got a little blip in it that shouldn't be there, that's macular degeneration. If you're looking at a picket fence and there's a little, wobbling in the, or if you're looking at the horizon, anything that should be straight and it's not straight, you got to think it's macular degeneration. There are these sort of grids that we can give patients. It's like it looks like graph paper, and you start seeing a distortion. Again, we need to see you right away. There is a device called the 4C Home, which is now covered by Medicare, and patients can sort of look in this, and it's like a video game, but it's looking for macular degeneration. Studies have shown that this is the earliest way to pick up what is called wet macular degeneration. Wet macular degeneration this is the dry, the drusen, but these drusen can cause the inducement of blood vessels into this area of the eye. And this is what can happen. So if someone comes in, they go to sleep one night, they wake up the next day, they can't see. And this is what we're seeing. This is a wet macular degeneration where they've hemorrhaged into the tissues of the retina. At this point, there's little we're going to be able to do for this person. In the past, we had to use fluorescein angiogram, which was an invasive procedure. We start an IV, we inject the dye into their vein, we take pictures. It required a good photographer to do this, and we would be looking for signs of leakage. And this shows us that this patient has early wet macular degeneration. This is a time where we want to catch these folks because we can, again, more aggressively treat them, which I'll show you in a minute. Now we can take a picture. This takes around 5 seconds in the office. You can shoot these things day in and day out. It's non-invasive. It's just like getting a picture taken. And we can start picking up these changes that you can see right here. This is leakage underneath the retina. This is the beginning of wet macular degeneration before this patient is hemorrhaged. In 2009, this is the first study that came out and showed that we as physicians could affect wet macular degeneration. It was called the ANCHOR study, and typically patients exonerably lost vision if they had the diagnosis of wet macular degeneration. With the use of injection therapy, and I'm sure a lot of you have friends that are going to the doctors now on every 6 to 12-week basis, getting these injections, and now we not only preserve vision, but actually improved vision in people who presented with wet macular degeneration. This shows an example of, again, using the OCT device to follow how the therapy is working. We can see this patient has fluid underneath their retina, and we can see how the fluid over time has allowed this fluid to dissipate and the retina return to normal function. So in conclusion, advances in diagnosing, the imaging, monitoring, and the treatment of macular degeneration has turned a disease which is exonerably into loss of vision to one which now we can, in many patients, maintain their vision. So I think that's the end of my formal presentation. I know we covered a lot of ground. If there's any questions, I'd be more than happy to. Yes, Julie will bring the mic around.
Thank you very much. 2 questions relating to glaucoma and the Meeks treatment that you explained earlier, and they're related. One is it possible to install multiple devices in one treatment? And the other is, do they impact the use of either CT or MRI scanning afterwards? I know I have a son who does metalworking, and he's always advised to have his eyes x-rayed prior to an MRI. Is it related?
Yeah, as far as the second question, I suppose a radiologist would pick one of these up and would make question whether you have a piece of metal in your eye. These are made out of titanium, so it would not impact your ability to have an MRI or anything else. So once you have one of these in your eye, you can pretty much forget about it. It's not going to impact anything ever again that you're likely to experience. As far as the first question, theoretically, yes, you can have more than one of these devices put in your eye. From a practical point of view, insurance is not going to cover it. So I hope that answers that question. Hi.
I have a few questions. One is macular problems hereditary, genetic?
There is a definite strong hereditary aspect to macular degeneration, and the genetics are being worked out more and more. As a matter of fact, one of the major centers up at Mass Eye, they are working aggressively on studying the genetics of macular degeneration.
My second question is, I have a friend who, her husband and herself have just developed this macular and problems with their, what was the first one? With the, not just the macular, but the, what was the other? Cataract.
Yep.
They're having problems, and their husband and wife, I'm wondering if there's something lacking in their diet, that they're both lacking, that they're both developing these pressure problems and the macular.
These are both very common conditions, so they're not rare conditions. Again, 40% of us are going to probably come to have cataract surgery in our lifetime. We're living longer. We are staying more active. So, and the operation's less invasive, so more people are having cataract surgery. So if you figure that's almost half of the people in this room are going to have cataract surgery in their lifetime. And if you figure the incidence of macular degeneration to some extent is also very common. So the fact that 2 people had both conditions I don't think is uncommon at all.
Okay, my last question is, as far as the lens replacement, are they still doing, like if you need glasses to see far away and glasses to see up close, are they still doing like one lens that's far away and the other eye, the lens that's up close?
What she's talking about, it's a concept called monovision. Why it's called monovision, I don't know. I don't think it's a very good term, but it's a concept where one eye sees near, one eye sees far. And we've done that with contact lenses with folks. And it seems like when people are young and you start making one eye, you start undercorrecting is what we're doing in a nearsighted patient primarily. You're allowing them to have more near vision with one eye, and it sort of precludes or decreases their necessity to have reading glasses. You can also do that when you do LASIK surgery. I had LASIK surgery. I was 47. I was struggling with near and far. I had one eye done for near, one eye done for far. I'm still not wearing glasses. So that does work, and we can do the same exact thing with our monocular or monofocal lenses that we have when we do cataract surgery. The problem is it breaks up binocularity. Your brain is used to seeing both eyes working together, and the amount of neural processing that goes on, you gotta remember, more of your brain is committed to the sight of vision than everything else. So there's a lot of brain power goes into seeing. And when you're starting to break up binocularity and sending one image in one eye and another image to the brain via another eye, the brain has a hard time. Some people do well with it, some people do not. So if you have that done at the time of cataract surgery and you don't like it, you're stuck.
So
So
they can't be
people that
taken
have
out.
had have had like LASIK surgery or have done contact lenses who have demonstrated the ability to tolerate that, then yeah, we do that regularly in those people. Other people, we often offer that, but it's hard to recommend that without them having tried it. And unfortunately, although you can try it with contact lenses, by the time they're getting cataract surgery, they don't have good enough vision to do the trial, to really know if that's going to work for them or not. So the answer is yes, but one needs to be cautious when they take that approach.
So once they put them in, you can't take them out and
Well,
put the multi.
It's much riskier taking a lens out of the eye than putting one in.
Okay. Thank you very much.
Oh, you're welcome. Julie, should I call on people?
Hi, doctor. If you're being treated and followed by an optometrist for, glaucoma or cataract disease, when should you switch to an ophthalmologist?
I would say, I think if you have, the optometrists are trained to follow disease. They really are. And most of them, I think, on the Cape, we have really high-quality optometrists, by and large, on Cape Cod. I think most of them, when they feel as though something more than they're comfortable handling arises, they've been very good about sending you our way. So I would talk to your optometrist, and if he's following something, ask him, how comfortable are you following this? You're comfortable? And they say, yes, I think you're probably okay. Once you have any of these diseases, especially glaucoma, in this state, glaucoma cannot be treated by our optometry colleagues. It really needs to be treated by an MD, by an ophthalmologist. So if you have glaucoma or if there's serious suspicion of it, it's not unreasonable to come in and have that reevaluated by us. But again, by and large, I think the optometrists have been very responsible at steering the correct patients to see us.
Are you staying for more questions?
Yeah, I'll be more than happy to stay for questions, but after the session. So
Yeah, Dr. Oates has agreed to kind of stay until the end. So if you have more questions, you can really reach him at that.
Well, thank you
Thank
very
you so
much.
much, Doctor.